Good morning, everyone. We apologize for the delay and a bit of a transition switch with the sessions this morning. Dr. Prespaluski was unable to do the 9 o'clock Eastern Time session on low-risk MDS. However, she will be presenting later today at 1 o'clock. So we'll still have the presentation. We're just changing a couple of the times. And for anyone who is missing any of these, they will all be available on demand through the attendee hub. So whether you registered virtually or in person, you'll be able to see all of the presentations. So with that said, welcome to the conference session titled Transplant and Bone Marrow Failure. Thank you for joining us. My name is Alice Hauk. I'm the Senior Director of Patient and Professional Services at the Aplastic Anemia and MDS International Foundation, and I'll be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. Submit your entire question all at the same time, and also please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. George Chen. Dr. Chen is an Associate Professor of Oncology here at Roswell Park Cancer Center, an Associate Professor of Medicine at Jacobs School of Medicine and Biomedical Sciences, State University of New York at Buffalo. He completed his residency and a fellowship in Houston, Texas at Baylor College of Medicine, and an additional fellowship in Palo Alto, California at Stanford University. He is board certified in internal medicine, hematology, and medical oncology. Dr. Chen has a special interest in stem cell transplant, chronic graft-versus-host disease, and aplastic anemia. He specializes in acute and chronic leukemia and lymphoma. Welcome, Dr. Chen.
Hi. Hello? Can you hear me? Okay. Good morning. Thanks, Alice, for the introduction. Very happy to be here, to be able to present to you. Just out of curiosity, what have we gone through? What have been the sessions this morning already? This is the first one. Oh, okay. Well, so this is okay. Anyway, so we'll get started. So we're gonna talk about stem cell transplant for aplastic anemia and MDS today, and it's mostly about the logistics of how we do a transplant. We'll touch a little bit on the why, specifically for MDS and aplastic anemia, but I suspect the other speakers will also talk a little bit about that as well. Okay, so usually when I see patients, they come referred to me from their primary oncologist, either their hematologist or their leukemia doctor, who has looked over their chart and worked with the patient, and after some period of time decided that the patient may or may not need a transplant. In the majority of time, the primary doctor is right about whether or not the patient needs a transplant. So now that the primary physician has recommended a transplant, what happens next? And so we'll cover what a hematopoietic cell transplant is, how it works, how it's done, specifically at Roswell, because every transplant center does things a little bit differently. And then what are some of the other considerations patients should make before committing to a allogeneic transplant. So a stem cell transplant is the transfer of hematopoietic progenitor and stem cells for therapeutic purposes. And as far as patients are concerned, you can just call it a hematopoietic cell transplant. Some of the other names that are used are bone marrow transplant, hematopoietic stem cell transplant, hematopoietic progenitor cell transplant, and peripheral blood stem cell transplant. For the most part, if you say hematopoietic cell transplant, people will know what you're talking about. These other names are really only relevant really to transplant doctors because they reflect on the specific cells and techniques used. But for most everyone else, hematopoietic cell transplant is a good term to use. And so this is the basic schema for a hematopoietic cell transplant. And let's see if this works. Okay, right. So these are patients. And in this case, this is probably most reflective of a patient with myelodysplastic syndrome. And so what happens is that patients have MDS, and this square box represents your bone marrow. So as you know, MDS is a disease of the bone marrow. You have these abnormal, potentially malignant cells in the bone marrow. And so with your primary physician, the patients are undergoing disease-specific treatments, in this case probably something like demethylating therapy. And with the demethylating therapy, the amount of myelodysplastic syndrome in the bone marrow is gradually reduced over a period of several months. And so at this point, when the disease is under reasonable control, patients will come to an allogeneic transplant. And as part of it, they undergo a conditioning regimen which consists of chemotherapy and sometimes radiation. The effect of this is to empty out their bone marrow in addition to the myelodysplastic cells. So we are getting rid of the diseased bone marrow. And then once you are empty, we would give you a donor cell infusion of allogeneic stem cells. And so these stem cells are given by infusion like a blood transfusion. It's very anticlimactic when it happens. It takes maybe 30 minutes. And then after about 2 or 3 weeks, these stem cells gradually regrow. The stem cells become white blood cells, red blood cells, and platelets. And then you have reconstitution of the peripheral white blood cell counts and platelet counts, and then over time, you have an entirely new bone marrow and hematopoietic system. So that's kind of an overview of how an allogeneic transplant goes. And the reason that the transplant works is because of this. So this is the hematopoietic cell hierarchy. And so what we're working with, this is not working. Or maybe it just doesn't. Oh, there we go. Oh, maybe if I do this. Okay, well, do you see my arrow? Yeah, this is much easier actually. So this is the hematopoietic cell hierarchy, and what we're working with in an allogeneic transplant is transferring these stem cells. And so these stem cells will self-renew, but they will also divide. And when the cells divide, they become more differentiated, and they become your white blood cells, and then your red blood cells, and then your platelets, and then a few other kinds of cells that are derived from the bone marrow. And so because we can transfer this, these are healthy stem cells from healthy donors, this replaces the unhealthy bone marrow that is present in patients with myelodysplastic syndrome, or the absent bone marrow cells that occurs in aplastic anemia. Okay, so this is another view of the process. So up here, this is the aplastic anemia specific pathway, and then this is the myelodysplastic syndrome specific pathway. And so these are the donor cells, and the patients start out here, and then they undergo some kind of conditioning regimen. So the conditioning regimen is tailored to either myelodysplastic syndrome or, MDS or aplastic anemia. The end result is that you have a patient with an empty bone marrow or relatively empty bone marrow, and then after infusion of the stem cells, you have gradual reconstitution of healthy hematopoiesis, and then over time, eventually full reconstitution. And so you'll note that there's still, with MDS, there's still a little bit of the myelodysplastic cell clone that is present throughout the process, even when the stem cells are infused, whereas this is not present for aplastic anemia. And so because there is this persistence, part of getting an allogeneic transplant for MDS is that the graft also exerts an immunologic effect against the recipient's native myelodysplastic cells, and this immunologic effect, which we call the graft versus leukemia effect, gradually gets rid of the malignant clone over time. So you may still have a little bit even after, at least in the first 3 or 4 weeks after you get the stem cells, but the hope is that the donor's immune system will react against the recipient's malignant clone and get rid of it over time. And so because of this, the way we manage the immunosuppression, which we have to give after the stem cells, is a little bit different for MDS as opposed to aplastic anemia. For aplastic anemia, there is really not a malignant clone, and the problem here is just replacement of hematopoiesis. So we can do that easily by giving the donor stem cells, and then they just grow, and we can give as much immunosuppression as we like to prevent graft versus host disease, and then things will work out. Whereas we cannot give as much immunosuppression as we like in the setting of myelodysplastic syndrome, because then we run the risk of suppressing the donor's immune system against the recipient's malignant clone, and that might reduce the effectiveness of the allogeneic transplant for MDS. Okay, so now we'll go through the logistics of how a transplant is done. And so, there are many phases to this. There's a pre-transplant phase, and then the actual transplant, and then the post-transplant phase. And so much of the pre-transplant and transplant phases are done behind the scenes. And so these include things like identifying a donor for you, because we cannot do a transplant without a donor, arranging to have the donor cells brought to Buffalo. And then while this is happening, the patients continue treatment with their primary oncologist, so they continue receiving treatment for their myelodysplastic syndrome, or they continue getting transfusions or immunosuppression for their aplastic anemia. And then once everything has been arranged and we have dates, the patient is brought in for a conditioning regimen when they get their cells infused. Okay, so this is what. So the most important thing to finding a donor is HLA matching, and so HLA stands for human leukocyte antigen, and so there are 2 classes of HLA proteins on our cells, class 1 and class 2. And in terms of, with regard to transplant, we look at 12 different HLA molecules when we think about how to choose grafts for patients. And so so this is a table of the different HLA molecules that we look at. Humans inherit one HLA, so there are actually 6 different kinds of HLA molecules: DRB1, B, A, C, DQ, and DP. And so humans inherit one set from their mom and the other set from their dad. So that's where we get 12 antigens to look at. And so these molecules are encoded on chromosome 6. So you get one from your mom, one from your dad. And they are expressed on almost all cells of your body. So Your hematopoietic cells will express 12 of these antigens, the class 1 and 2 antigens, and then the rest of the cells on your body will only express class 1 antigens. And this is how the haplotypes are inherited. As I mentioned before, you get one copy from your mom and one copy from your dad. So, 50% of what you have is from mom, 50% is from dad. And so if you have siblings, they also have a similar chance of inheriting, but they may not inherit the same copy. And so if you have one brother, you have a 25% chance of having the same HLA molecules. And if you have more siblings, you have a higher chance of finding an HLA-matched sibling within your family. But this kind of plateaus after a while at around, I think it's around 70%. And this is the equation that we use to calculate the chance. Of course, this is all chance. You could have 10 siblings. I've had patients that have had 6 siblings and no one has matched. And then I've had patients that have had 1 sibling and that sibling was the match. So it's all, unfortunately, it's all related. Well, fortunately, it's all related to chance. Okay, and so this is what happens when we're looking at donors. So at the beginning of the process, we will draw blood from you and we will send that off for HLA typing. And it takes probably about 2 or 3 weeks for the lab to fully type the haplotypes. And so, for example, if this is PT stands for the patient, and this is a totally made up haplotype because if I show you a real one, I'm violating HIPAA. But this is a totally made up one. And so, this is kind of what we get from the lab. We get things like A*01, A*02, and then so on and so forth. And so there are 12 antigens that come out. And then we also have baseline data that is sometimes relevant to the donor selection process, such as age, CMV status. So sex and blood usually don't matter very much in terms of selecting donors. You can have a male donor and be a female patient, or the reverse, or you can have a same-sex donor-recipient pair. And then blood type also does not really matter with regard to donor selection. You can have an A into an O, or you could have an A into an O or an O into A, which makes more sense, which is what is normally done. But the ABO blood type really doesn't matter. And so what matters is the haplotype, and then the age of the donor, and then CMV status also sometimes matters. And so if this is the patient, then what happens when we get this listing is that the transplant coordinator will type this data into the National Marrow Donor Program registry, which is a database of all of the donors worldwide that are willing to donate bone marrow or stem cells to other people. And when they do that, the database will generate a list of potential donors. And so, for example, that could be numbers 1 through 6 in this list. Some patients are very lucky. They literally have hundreds of donors. And then, you can choose the very best ones that you want. Some patients are kind of unlucky. They get only 3 or 4 donors, and these donors are in hard to reach places, or places where it's very difficult to get stem cells. So, for example, having donors from the United States makes it very easy because, we're all in the same country, and so there aren't as many restrictions. And there's great infrastructure in the United States for procuring donor cells. But for example, if the donor is from a place like Brazil, which tends to be a very difficult place because, well, I don't know why, but the joke is that they're lost in the rainforest or they're too busy during carnival partying. But, it's very hard to get donors from Brazil. The time for getting cells is prolonged, and so sometimes we will choose donors from other countries because of that. So anyways, there's a list of the NMDP database generates a list of potential donors, and then at some point, the transplant doctor and the transplant coordinator sit down and look at the data to pick out potential donors to request additional blood samples from so that we can type them in our own labs to make sure that the typing done by the National Marrow Donor Program and other registries matches our typing, because you don't want to give a product that you don't really know the haplotype for. And then once we pick out the first 2 or 3, we send off requests for these cells, and then it takes 3 or 4 weeks for the potential donor to be contacted and to have his or her blood drawn and to have the blood sent back to Buffalo. So this is where, you kind of, usually if the potential donor is interested in donating, they'll answer right away. Sometimes the potential donor has other things going on in their life, like they're getting married, they're going on vacation, and so sometimes that delays the response. The other things that can delay the response are the donor's pregnant. You can't collect stem cells from a pregnant donor because then you are potentially jeopardizing the safety and health of the donor. So that donor is then out of circulation for 9 months. And so this is probably the most time-consuming part of finding a donor, is waiting for the potential donor to respond and to send back cells and to get the typing done. And so with regard to choosing which donor to go for, we look at things like the HLA typing. And so, for example, number 1 has the exact same HLA type as the patient. And number 2 also has the same HLA type as the patient. And really the only differences between number 1 is the age, 45 years old versus 22 years old. And so in this case, we would choose number 2 because the donor is younger, and so the age of the donor has an impact on the overall survival of patients after allogeneic transplant. So the younger your donor, the better your overall survival. It's probably about 3 percentage points per decade of difference in donor age. So here there are 2 decades of difference times 3. So that's, this donor number 2 is predicted to give you a 6% chance of better overall survival compared to this 45-year-old equally matched donor. Yeah, and so that's why we would choose number 2 in this case. So let's say so let's say the patient is kind of unlucky, and they don't have any fully matched donors. So in this case, 12 out of 12 donors, and so that would be so then. When the transplant coordinator types in the donor search, numbers 1, 2, 3, and 4 are not there. The only donors that come up are number 5 and number 6. So number 5 is, and so the differences I've highlighted in red here. So number 5 is mismatched at DQ, one of the HLA antigens, also very young. And then number 6 is mismatched at B, one of the other HLA molecules. And so in this case, we would choose number 5 because mismatching at DQ and DP is preferred to mismatching at A, B, C, and DRB1. And then of course this one is mismatched, so that we would try to avoid that. But sometimes it just depends on which donors come up for you, for the patient. Sometimes there are no other donors besides donors that are mismatched at A, B, C, DRB1. There is an alternative donor source. You can look inside of your family for donors. So if you're lucky enough to have a matched sibling donor, then we can use that donor. There's some controversy over whether an older matched sibling donor, so like a 60-year-old matched sibling donor, is better than a matched, unrelated donor that is younger in their 20s or 24. But that's kind of a question that the transplant doctors settle amongst themselves. And then if there are no matched donors at all anywhere to be found, it is possible to do what we call a haploidentical transplant, which uses relatives that only inherit, which uses relatives that the patient only shares one set of HLA molecules with. So either the set inherited from the mom or the set inherited from your dad. So most of our patients are in their 50s and 60s, and they have children who are adults, meaning they're older than 18 years old, that that by definition will only share half of their HLA molecules because they inherit the other half from their father. And so in some cases, it is possible to use this haploidentical related donor, even though it is mismatched at all of these places, as the donor for a stem cell transplant. And the reason that we can do this is because of the technique that is used to do the actual transplant, which we won't go into today, but I'll just, it's there if we need to use it. And so after finding the donor that has the best HLA match to the recipient, then the other consideration is what kind of cell to give. And so here at Roswell, there are there are actually two main types that we give: peripheral blood stem cells and bone marrow cells. We do the occasional cord blood, but that's pretty rare. And so this is how bone marrow cells are collected. The donor goes to the operating room and they are put on their stomach. And then we take these large needles and we insert them into the patient's hip and we suck out the marrow from the hip. So each of these syringes is about 20 mLs. And so the average bone marrow graft size is somewhere around 1.5 to 2 liters. So that's like 100 of these tubes being pulled out of the bone marrow. And so that process takes anywhere from 2 to 3 hours. Thankfully, the patient receives thankfully the donor receives, the donor receives general anesthesia during this process. So hopefully they're comfortable. But the donor is sore for probably a day or two from having all of the biopsies done, heart biopsies and aspirates done during the harvest. And so this is what the bone marrow that is sucked out looks like. It's put into this bag, and then this is sent off to the stem cell lab where it's filtered to take out all of the bony particles and grit that comes out with the marrow. And then once that has happened, the cells are counted, and then it's shipped off to whatever center needs the cells, if it's an unrelated graft, or if it's a bone marrow collection for a related person, then this bag is taken to the transplant unit and infused, just like a blood transfusion. And so this is just cord blood, and so this is just an example of cord blood. It's actually taken from the placenta of babies that have been delivered. And then this is what a peripheral blood stem cell collection looks like. It involves a machine that looks like a dialysis machine right here. It's about the size of a washing machine. And so what happens is that the donor receives growth factor to mobilize the bone marrow cells into the peripheral blood, and then the donor is hooked up to this machine, he or she gets an intravenous line, gets 2 intravenous lines, one in each arm, and so the blood flows from the donor through one of the lines into the machine, and that gets spun around, and the stem cells are isolated from that, and then the rest of the blood is sent back to the donor. Okay, so how is a transplant actually done? So once we have the stem cells collected, either by harvest or by apheresis, and this is an illustration of stem cell collection by apheresis, then the patient, so once we have these cells, we freeze them nowadays. Before COVID, we didn't freeze them because it was just easier to do it that way. But now, because of COVID, there are problems with travel, and so we like to make sure we have all of the materials we need to do a transplant in hand before starting the transplant. And so the donor cells are collected and procured and sent to Buffalo, and they're stored. And then the patient comes in for conditioning chemotherapy to destroy the myelodysplastic cells, as well as to clear out the bone marrow from the native bone marrow from the patient. And so this could involve using chemotherapy drugs, as well as sometimes total body irradiation. And then once that is done, which takes about 5 to 7 days, depending on the regimen, then these stem cells are infused directly into the patient, just like a blood transfusion. And so during the stem cell infusion, it works like any blood infusion. The patient would receive pre-medications to prevent any side effects, such as blood product transfusion reactions. So this is a little bit different from just getting a red blood cell, because obviously you can't stop halfway. So if patients do develop some sort of transfusion reaction, then unfortunately, the medical staff just kind of powers through, and they will treat with steroids and IV fluids to control the reaction. But once the patients get to the infusion part of the transplant, it has to go forward. You cannot stop, because otherwise the patient will not have a bone marrow grow back, which is an even bigger problem. So if they develop a reaction, then they just power through. And so while the transfusion happens, if the stem cells have been cryopreserved ahead of time, which is almost always the case nowadays, there is a special smell that happens from the dimethyl sulfoxide that the stem cells are preserved in. And so this special smell is present in the recipient's room for days after the transplant. The patient doesn't smell it because they get used to it, but people who come into the room can smell it. And so it smells like creamed corn or boiled tomatoes. Some people say boiled garlic. I've had one fellow tell me it smells like freshly cut coconuts. Some people say it smells like oysters. I kind of think it smells like Tutti Frutti. But there's a special smell that is in the room from the solvent that the stem cells are cryopreserved in. And as part of the transplant, this solvent is infused into you, and then it kind of comes out through your sweat glands, and you breathe it out. And then eventually goes away. Okay, so this is very complicated, but this is kind of an overview of the whole transplant process. And so up here is the process for myelodysplastic syndrome, and then down here is the process for aplastic anemia. And so, patients come to us on the left, and so they still have myelodysplastic syndrome, or they don't have any bone marrow cells. And so when the initial consultation happens, we kind of make the decision to go forward or not with a transplant. And so assuming that the decision is made for a transplant, we collect blood samples from the patients, and we send it off for HLA typing. and then we don't see the patient for 2 or 3 months. And so during that 2 or 3 month period, the patients continue treatment by their leukemia physicians. They're either getting demethylating therapy or supportive care, immunosuppression for their aplastic anemia. And in the background, what we are doing is we are getting the HLA typing, and then we're doing the donor selection, which we talked about, and we're making arrangements for the cells to be shipped to Buffalo. And once we have the cells, we freeze them down so that we're ready. And then, so let's say we have the cells now, or we have the plan for the cells, and then and once we have that, we can get the patient scheduled for their allogeneic transplant. And once they're scheduled, they go through a conditioning regimen, which depletes their bone marrow of cells and also immunosuppresses them. And at this time, we can give the donor stem cells here and here. And so during this phase, and so once the cells have been given, then there's a period of about 14 to 28 days when the donor cells are gradually regrowing in the bone marrow. And then after many months, the patient is cured. So going from here to here can be easy or it can be arduous. It kind of depends on the complications that happen. And so the main complications that we worry about are infection and graft versus host disease. And so the time for the cells to regrow can be short. It could be 14 to 28 days. But the time from getting the transplant until recovery, and by recovery I mean that the patients are kind of back to their normal lives. They're not having to be seen at the hospital every week. Can be long. It can be anywhere. It can be as short as 6 months, or it can be as long as 24 months. Sometimes even longer. It just depends on what complications occur after transplant. And so we'll talk, I think, a little bit about the complications after transplant. So with regard to infection, the ones that we worry about are viral infections such as herpes and cytomegalovirus, as well as fungal infections, and then bacterial infections. And so because during the transplant process, the patients receive a conditioning regimen which depletes their bone marrow of cells, and there's a period of time when the donor's bone marrow cells are slowly regrowing. The patients are at risk for developing infections, and so during that time period, we'll give them antimicrobial agents. You'll get an antiviral drug, an antifungal drug, an antibacterial drug. There's also an antiparasitic drug that we give. So patients will be on at least 4 different antibiotics from the time they get their donor cells until they're off of immunosuppression. So it could be anywhere from 6 months to 12 months, sometimes longer, depending on what complications develop. And that's kind of all I'll say about infection, because even though it happens, there are good ways to deal with it. And then the other complication that we worry a lot after transplant is graft versus host disease. And so this comes in 2 flavors, acute and chronic graft versus host disease. Acute graft versus host disease is the reaction of the donor's immune system against the recipient's body tissues. And so usually they react against the skin, the liver, and the intestines. And so this can show up as diarrhea, which can be very, very bad. Sometimes patients have as much as 2 or 3 liters of diarrhea a day. Or it can show up as a skin rash, like in this picture. I didn't want to show a picture of diarrhea this morning. But the skin rash looks like a really bad sunburn, and it can be, usually in the sun-exposed areas. The classic manifestation is to have this sort of rash on your palms and on your soles and on the nape of your neck. Or it could be, and it could be something as mild as that, or it could be something really terrible, like having blisters forming and the entire skin sloughs off. And then, the other manifestation is liver function test abnormalities. And so these usually occur within the first 100 days. This is part of the reason that patients are hospitalized from the time they get their conditioning regimen until about a month after they get their cells, because that's the period of time when patients are most at risk for graft versus host disease. And so the nursing staff is well trained to look for diarrhea and skin rash. That's why when you're on the transplant unit, we usually ask the patients to defecate into a hat so we can measure the volume. And so anywhere from 20 to 50% of allogeneic transplants will develop some kind of acute GVHD. And in the past, the mortality was quite high. It used to be anywhere from 15 to 20% at day 100. Now it's probably around 6 to 10%, depending on the technique that is used. And if patients get acute graft versus host disease, then they're treated very aggressively. The primary treatment is high-dose corticosteroids, and then if the steroids don't work, then there are a variety of second and third-line agents that can be used. And then the other complication is chronic graft versus host disease. This is the flip side of, so this is a post-transplant complication, which usually occurs after 100 days. The symptoms are different from acute graft versus host disease. So chronic graft versus host disease includes things like fibrosis of the skin. It looks a little bit like scleroderma, and the other symptoms include dry and gritty mouth and eyes because the salivary glands and the tear glands are destroyed by the immune reaction of the donor against the patient's body. And then sometimes patients can also have fibrosis of their gastrointestinal tract. So this is, there are plus and minus sides to chronic graft versus host disease. This is the reaction of the donor cells against the recipient's body tissues. And to some extent, this is what we want, because myelodysplastic disease also is made of the recipient's body tissues, so we want the donor cells to react against that. But this is the flip side, meaning it's too much of a good thing. And so patients can have very mild chronic graft versus host disease, or they can have very severe chronic graft versus host disease. Having chronic graft versus host disease is actually associated with less relapse after transplant. So to some extent, it's good as long as it is mild and controlled, although you can still have the graft versus leukemia or myelodysplastic syndrome effect even if patients don't have chronic graft versus host disease. And so this occurs pretty frequently. Up to about 50% of long-term survivors will have some form of chronic graft versus host disease. It's usually very mild, but it is also the cause of major long-term mortality after transplant. And so these are some examples of bad chronic graft versus host disease. Most patients don't get this bad. And so in this picture, you can see that the patient has the dry, leathery, and fibrotic skin that sometimes happens after transplant. So this poor person is trying to lift his arms above his shoulders, but he can't because the tissues have they've tightened. So the skin is not elastic enough for him to raise his arms above his shoulders. This is an example of fasciitis that happens after allogeneic transplant and with chronic graft versus host disease. It's just kind of tightening of the skin at the fascia, and you can see the same thing here in this patient across the shoulders. This is an example of very mild chronic GVHD, so this is just a little bit of dry skin. It's something that you could treat with some steroid ointment or moisturizer. And this is an example of oral chronic graft versus host disease. So you see a little bit of fibrosis here, and then there's some little blisters here. And I think, oh, okay. And so for the treatment for chronic graft versus host disease is immunosuppression. And so when we looked at how long patients are on immunosuppression, patients are able to come off, about 70% are able to come off of treatment for chronic graft versus host disease, but about 30% are, well, actually, yes, so this is, right, yeah. So in this case, about 70% are able to come off of immunosuppression, but 30% remain on immunosuppression. Sorry, I got my axes mixed up. And so what this means for patients is that they can have MDS and they go through the transplant, and as far as we know, their bone marrow looks normal, but they have this very mild chronic graft versus host disease that is persistent in their bodies for, as long as 10 years after the transplant. And in this case, they are still on medications, usually some kind of immunosuppression to keep their donor's immune system from further reacting against their bodies and causing more chronic graft versus host disease. Okay, and so there are some considerations patients should make before committing to an allogeneic transplant. On the plus side is potential cure of the underlying disease. This is probably the only curative therapy for myelodysplastic syndrome and for aplastic anemia. Everything else is is treating symptoms and kind of putting a bandage on the process, because these are disorders of the bone marrow, and so with this procedure you have replacement of unhealthy bone marrow with potentially healthy bone marrow. And so I think that is a large draw of the process. On the flip side of it is that this is a pretty intense medical procedure. We're talking about 6 to 24 months of being seen at a hospital, being seen by physicians, being poked and prodded with needles, and so it can be quite burdensome at times. And plus there is also a prolonged hospitalization that occurs with a transplant. Patients sometimes are in the hospital for up to a month. If they have complications from transplant, such as acute graft versus host disease or chronic graft versus host disease or infection, then that adds to their hospitalization time. Some patients are in the hospital for 3 months at a time. And so I think, these are things that patients should consider. I think if patients are young, they're in their 20s, they're in their 40s, they're in their 50s, they have their entire lives ahead of them. A year or two spent doing something that could potentially allow them to have another 20, 30 years of life is probably worth it. But if the patient is elderly, maybe they're 75, they're not in the best of health, then I think they really need to think twice before committing to an allogeneic transplant, because I think the reality is 75 to about 80 is probably about the average lifespan. And so if you are not expected normally to live that long, to spend the last few years of your life doing something like an allogeneic transplant when you could be doing other things, it may not be worth your time. So I think these are the considerations that patients need to make before committing to an allogeneic transplant. And so I think that's my last slide, and I'll take any questions now, if you have any.
If anyone has questions, I can bring the mic to you. We have a couple of questions online. Okay, I'll bring this over.
Thank you. If you were to choose not to do this transplant, can you get blood transfusions that would help you if you had the problem?
Yeah, I mean, you can always get blood transfusions, right? So if, it just depends on the specifics of your case, but, you can always continue, the treatments that are given to you by your leukemia doctors.
Thank you.
We do have a question from online. How does Gameta's new product, Amidubicel, I may be not saying that correctly, Amidubicel help? Is it for people with no donor?
I'm not sure what that product is. Sorry. Do they?
That's all I have. If the person who submitted the question, if they want to add more detail.
I'm sorry, I don't know what that product is.
Okay, we have another question. Is the PTCY clinical trial active at Roswell, and does that make outcomes better?
Yeah, so PTCY stands for post-transplant cyclophosphamide, and this is a way of dealing with acute graft versus host disease, and so this is something that is done here at Roswell. It's mostly done in the setting of haploidentical transplants or mismatched allogeneic transplants, and so here there is a clinical trial, and so that's done as, for haploidentical transplants, it's done as the standard of care, and for the mismatched and for matched transplants, it's done as part of a clinical trial.
Are there other clinical trials that may be available for potential transplant patients?
Yeah, there are. There are many. They can at Roswell. There's a website. I would refer the questioner to the Roswell website, where there's a listing of all the clinical trials that are available from the transplant service. And then if there's something that they think is applicable to them, then they can contact the transplant service and arrange for a consult.
Another question we receive commonly in webinars and from patients who have gone through a transplant, do immunizations have to be done over again post-transplant?
Yeah. So typically we will vaccinate patients at 6 months after allogeneic transplant and as well as after autologous transplant. And so that, there's different prioritization of which vaccines are received. Right now we're prioritizing COVID vaccines over everything else. And then once those are done, then we go through all of the childhood immunizations.
And I know you touched on this somewhat during your presentation, but as far as someone who's recently diagnosed with any of the diseases that we're talking about today, how soon should they begin the process of looking for a donor, even if that is not yet an option that is imminent? How soon should they start the process?
Yeah, so I think the earlier the better. As soon as, perhaps even as soon as the primary oncologist starts mentioning an allogeneic transplant, or even thinking about an allogeneic transplant, then the patients should be referred. Finding a donor is the longest part of the process. Sometimes, it can take 2 months, but sometimes it can take 6 months. It just depends on who the patient is and on how many potential donors there are out there. So if you are very unlucky and your National Marrow Donor Program search only comes up with 3 potential donors, then it's very likely that you're going to have that patient will have a prolonged donor search. If the patient has 10 siblings and they all live in the city, then the donor search may be very short. But usually the earlier the better.
I have some clarification on that earlier question. So omidubicel by Gamida has been accepted for FDA review by January 20th. It is for patients with no donor and is compared to cord blood for results comparison. Some have suggested it's only to extend cord blood.
Yeah, so I mean, it sounds like maybe a off-the-shelf stem cell product. So I think I've not heard anything about it. I think it might be starting in clinical trials, but I don't think we have that clinical trial here at Roswell, and I'm not sure that even if it were FDA approved, if I would use that preferentially over a standard allogeneic transplant, because it is relatively new, and so we don't really know what the characteristics are. I think this is probably in clinical trials. That's what it sounds like from the question. Unfortunately, I can't be more specific without knowing actual details.
What do you recommend that patients and their families consider for support needed, both pre and post transplant? How do you and your colleagues talk with them about what you've outlined what to expect during the transplant process, but the broader support that they need? What do you recommend they really think about as part of the transplant process?
I think support is essential. They definitely need support. Usually there is a requirement for a 24/7 caregiver during the actual first 100 days of the transplant. And so usually this caregiver is a spouse or child or friend or relative. It doesn't have to be all the same person, but the patients really do need someone to be with them 24/7, to serve as an extra pair of eyes and hands to go get help if the patient is ill, sometimes to make the patient take his or her medicines, because sometimes that falls by the wayside. So I think having a caregiver is very important. I think good coordination with the transplant team with regard to timing of the transplant and what's going on with primary therapy for MDS or aplastic anemia is also very important.
Thank you. And one further clarification with the drug mentioned earlier, omidubicel is in phase 1 and 2 presently.
Yeah,
so
it's it's a clinical trial. So I would, of course, I think it's important to support clinical trials, but I think if there is a standard of care treatment that is available, like a well-matched, young, unrelated or related stem cell donor, then I would probably use that. But I don't know. I mean, I don't really know. We don't have that trial here at Roswell, so I don't really know.
I'm just curious, if you have more than one bone marrow failure disease, does that decrease your odds of a transplant being successful?
No. I mean, it's the transplant. I mean, it's the same bone marrow that has the problem, and so the part of the transplant process is getting rid of all of that, and then replacing it with healthy bone marrow. So it shouldn't make a difference.
And one final question. With the age considerations for someone with MDS, aside from age, what other factors do you look at, even if someone is over age 70 or, you had mentioned 75 as a general age to really consider transplant? What are the other factors that you look at, just to
Yeah.
clarify that
I
further?
mean, the age is kind of a guideline. Usually, we usually say 75. Occasionally, patients who are older are transplanted. And so in that case, the main consideration is the fitness level of the patient. So, there are some extremely healthy and fit people older than 75 that could tolerate a transplant. So usually these are the 75-year-olds that are out running marathons. But at baseline, they have a lot of reserve in terms of organ function, and so because of that, if complications happen during the transplant, they're able to rally and overcome those complications. And I think so this is why younger people tend to have an easier time, because they could tolerate being on steroids and having infections and having a prolonged hospital course, whereas older people have a harder time overcoming these things. But certainly if an older person older than 75 is fit and is otherwise healthy except for their disease, then certainly those people can be considered for allogeneic transplant, as long as other factors are working for them. So for example, if there's a super healthy 77-year-old that has a perfect donor, so meaning matched at 12 out of 12 antigens, 20 years old, then yeah, I think it's probably reasonable to try to do an allogeneic transplant in that setting. But it's all about kind of predicting how well you think the patient will do. If there are factors that make you nervous, that make you think that, oh, this is not going to be easy, and for example, the donor is not optimal, then even then it may not be possible to do an allogeneic transplant. But it is possible to do allogeneic transplants in very, very healthy older people.
Thank you. And we have one final question from online. How do genetic abnormalities affect transplant?
Yeah, so the genetic abnormalities are usually, it depends on where the genetic abnormalities are. If the genetic abnormalities are because of the myelodysplastic syndrome or because of the aplastic anemia, then those will eventually go away when the transplant is done. So for example, if the myelodysplastic syndrome has a RUNX1, well, I don't know if they have that. If the myelodysplastic syndrome has some kind of genetic mutation that was found and is being used to follow that disease, then that mutation will go away after the transplant is done, because the diseased bone marrow has been replaced by healthy bone marrow in the process.
Thank you, Dr. Chen, for sharing your time and expertise with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. This concludes the educational session of the transplantation education session of this conference. We hope you will join us later for our support groups. If you are online, please use the Zoom link provided to join the support groups. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 39 years. This concludes the session.
Thank you.